like the other speakers, I'm condensing a ton of material into 10 minutes or so. So please bear with me. So I was asked to speak on a subject of importance in the adult population. And this is a question that comes up a lot. Do I really need a biopsy? So I thought I'd discuss that. And the speakers before me are making it easy for me because they already kind of set everything up. But let's go over a little bit on the pathophysiology of the celiac disease. So what we have here is that a dietary protein, in this case gluten, when ingested by a subset of genetically predisposed individuals, it causes an inappropriate immune response. And that leads to activation of the immune response and inflammation, and ultimately that leads to the body attacking itself. In this case, the target organ is the small intestine. And as others have shown before, the changes are pretty obvious. So on the left side, what you have is a healthy small intestine, very nice, delicate villi, delicate folds, and the villi you could see, it looks almost like a sea anemone to me. It's a beautiful organ. However, after a person has celiac disease, what happens is destruction of this beautiful lining, and what you have is, this is a good example of scalloping. There's what we call mucosal depressions, and it could be nodular, but at the end, what you have is more like a snakeskin-like appearance. And in this form, the intestine cannot do its job, which is both for you to absorb nutrients, and also it's an important immunological organ. And as we heard, that the only available treatment at this time is avoiding gluten. And that's not trivial. So patients have to learn the skill, first learning what the gluten-free diet is, then implementing the gluten-free diet, and then maintaining it. And the gluten-free diet, as was said before, requires a lifelong commitment. It could be cumbersome, it could be expensive, it could adversely affect the quality of life. So we strive to make an accurate diagnosis. We want to recommend a gluten-free diet when it's indicated to prevent complications, and also it has implications for our families. And we want to avoid an inaccurate diagnosis because then we will falsely impose the burden of the gluten-free diet unnecessarily on our patients. And this I'm going to gloss over really quickly, but there's several different diagnostic tests that we have available to us. There's genetic testing, which, as you heard from before, patients who carry one of these two genes are predisposed for celiac disease. And sometimes we test for these genes in special circumstances. Sometimes it is to exclude celiac disease. Other times is because we need to more supporting evidence. Then there's the serologic testing or the antibody test, which Dr. Jericho already mentioned. And what we rely most on is the anti-tissue transglutaminase. These are screening tests. So if the clinical suspicion arises, then we check that first. And then we offer patients intestinal biopsy as a confirmatory test, and that's going to be the focus of my talk here. So what does that require? That requires a procedure that either requires sedation or anesthesia, and then we pass a camera that's basically a flexible scope with a camera into the small intestine, and we sample it. And here's that picture of the normal intestine. When you look at it under the microscope, you see that there's peaks and valleys. The peaks are the villi, and they're nice and tapery and finger-like. And then the valleys is what we call the crypt. So the crypt is usually very compact, and the villi should be at least 2.5 times taller than the crypt depth. However, in celiac disease, what you have is destruction of the villi, the crypts are very deep, and there's a lot of inflammation. So again, the intestine is impaired. So like everything, there's pros and cons to each approach. So what are the pros and cons of a biopsy? So on the pro side, the severity of the mucosal injury is better assessed by directly visualizing and sampling the small intestine. It provides for a more accurate diagnosis because there are other conditions that could cause mucosal injury just like celiac disease, but there's some subtle differences that we can make out under the microscope. It can reassure patients of the diagnosis, and also in adults, oftentimes celiac disease is a very common disease, so it overlaps with other diseases, and sometimes we find surprises that we diagnose other conditions. However, on the con side, biopsy can be expensive, and there is procedure risk, and there's also anesthesia risk, which would probably be a little bit more in children than in adults. But also there is some variability in the way that people interpret biopsies, so it's definitely not a perfect test. So there has been actually a movement to go towards a no biopsy diagnosis. And in Europe in 2012, some criteria were generated to do just that in children. These were recently revised, and in the current criteria is that if the tissue transglutaminase antibody test is very high, and the definition of very high is more than 10 times the upper limit of normal, and you could confirm a positive with another antibody, in this case anti-endomysial antibody, then you don't have to do a biopsy. This patient has celiac disease. And if the tissue transglutaminase is less than 10 times the upper limit of normal, then those patients get a biopsy. This is in Europe, and it's not uniformly applied in the United States, but it is used on a case-by-case basis for practical purposes. So a little bit on the antibody test. So tissue transglutaminase is a great screening test because it's highly sensitive and highly specific. In other words, when it's good at picking up the disease, and when it's positive, most of the time, it's accurate. However, nothing is 100%. And one of the things that I struggled with, and which is why I put it here, is that there are a lot of assays out there that test for tissue transglutaminase. And they don't all perform the same. And you will notice our patients can use Stanford Lab, Quest, PAMF, LabCorp, to name a few. And the normal values could be less than 0.4, less than 8, less than 15, less than 20. So that leads to some complexity as to if we are just using antibody tests. And this is a study that was done in Europe. So basically somebody took one patient's blood test and had it tested for tissue transglutaminase with many different assays. And as you can see, the values were very different. And this is a busy slide, but the bottom line is people have looked in the adult population that with patients that are symptomatic and see whether that criteria developed for children performs well in adults. And these are some of the highlights. So it's pretty clear that the higher the tissue transglutaminase, the more accurate it is at making the diagnosis. However, one of the drawbacks that was found is that the abnormal values vary depending on the assay that is used. One study was disturbing in that 2/3 of the patients that were diagnosed on the basis of abnormal serology had the wrong diagnosis. Now, this is not applying these criteria. This was, people with slightly positive and whatnot. So, but again, another one piece of evidence. If you do combine the tissue transglutaminase with another study, with another antibody, then the performance improves. And one study, they looked at applying the pediatric criteria to adults, and they thought, well, maybe if we make it 16 times the upper limit of normal, it'll be better in adults. And finally, there was an international study that looked at the positive predictive value and of the test and found that it was 95%. So in other words, 1 in 20 individuals could be misdiagnosed. So are we ready? Is this ready for prime time? In my humble opinion, not yet. First of all, the specificity of the serologic test is not 100%, no test is. So we do run the risk of misdiagnosing patients with celiac disease. There, again, lack of standardization of the commercially available test is a problem that we need to solve. And I think that the criteria has to be applied rigorously, because one of the challenges that I have is that people come in with slightly abnormal tissue transglutaminase or gliadin, and they're told, go on a gluten-free diet without a confirmatory biopsy, and then we're wondering what the diagnosis is. In adults, we often have many patients who continue to have symptoms, so it's nice to have a baseline that we could compare it to. And we would lose that if we go biopsy-free. And comorbid conditions could be missed. And also anti-endometrial antibody, which is a very accurate test for celiac disease, is difficult, and it's not available everywhere, and it's operator dependent, so we can't always rely on it as a second test. So in summary, what we can say is that very high tissue transglutaminase, 10 times the upper limit of normal, is highly suggestive of celiac disease. But the biopsy has clinical value in the diagnosis, and also it's great to have a no biopsy option, because even though endoscopy is safe in adults, sometimes we do have patients where it's risky. So in those situations, we might be able to apply this. Biopsy-free diagnosis has not been adopted yet in the diagnostic guidelines in the US. I think that one of the things that is a very bright spot is that there's a lot of research going on celiac disease. And I think that in the coming years, we're going to have much more understanding of the disease pathology and have other diagnostic tests that could help us go towards a better way of making the diagnosis, and maybe not relying on the biopsy, and have better ways that we can monitor people in the long term. And with that, I'd love to actually thank everybody who has participated in clinical research, because it's incredibly important, because this is the way that the field is going to advance, and this is the way that this is a human disease. So I truly, from my heart, appreciate everybody's effort on that. And with that, I will